This program is brought to you by Emory University.
Good morning, everyone. Happy Friday. Thank you for coming today. We have one of our esteemed first-year fellows, Martin Campbell, who will be speaking today about aortic disease. Martin joins us from Morehouse Medical School, and then he was a resident here at Emory and then a chief resident as well. We're looking forward to his talk today. Take it away, Martin.
All right. Thank you so much, Dr. Coley. Good morning, everybody. I know it's early on this Friday, but I'm very happy that you're here with me today. I really wanted to talk about aortic disease. So the title of my presentation is Aortic Disease Demystified, Key Insights for Cardiologists. In preparation for this presentation, I really tried to think about, what are one of those topics in cardiology, throughout my first year so far that I feel like still kind of like mysterious, or like when I'm in clinic, I kind of like still kind of don't know what to do. Maybe some of you can relate, but I feel like aortic disease definitely kind of checked off those boxes for me. Okay. I do not have any financial disclosures, unfortunately. The learning objectives today are to pretty much just define the different types of aortic diseases, being able to recognize the clinical features, what the risk factors are, the kind of how genetics play into all of that will be important. Additionally, appreciating the diagnostic approaches, the different imaging modalities, the different genetic tests, things that we screen for, and how we monitor aortic disease. I want you to take away from this presentation. And then thirdly, to understand the long-term management of aortopathies, including surveillance, surgical indications, and how you kind of personalize the care plans to patient-specific factors. So let's start off with the case presentation. So a 24-year-old male presents with acute onset blurred vision, tingling sensation in his right arm while playing basketball. He's pretty good at basketball as well. He was 6'6", very tall. He was also revered for his long wingspan. His family history of note was significant for aortic dissection and carotid aneurysm in his mother at age 44. He ultimately presented to the emergency room. They ended up doing a CTA, and it showed that he had an acute aortic dissection and an aortic aneurysm, very large, 6.7 centimeters. Emergently, he underwent surgery, specifically valve-sparing aortic root, ascending aorta, subtotal aortic arch, and descending thoracic aortic replacement. And he did pretty well from a surgical standpoint in like the short term, but months following his discharge, he had a drop in his ejection fraction down to 20%. And they thought it was due to an iatrogenic coarctation of the aorta from graft stenosis. And he was ultimately, developed cardiogenic shock, was admitted to the CCU, and then they ultimately got a pan-CTA, which revealed this here. So if you look here, there is, it appears to be a dissection on both sides here. So he had a dissection in his carotid, his common carotid artery, and also his vertebral artery. So he was evaluated by vascular surgery. They recommended just conservative management for those dissections. But ultimately, he underwent coarctation repair and open descending thoracic aorta replacement. Despite all of our efforts with pellet support, aortic repair, inotrope, so on and so forth, he continued to kind of spiral downward and ultimately was evaluated for cardiac transplant. And last I checked, when I checked in on his chart, he's actually doing pretty well. Trying to lead a normal life and otherwise pretty healthy. Ultimately, his genetic testing revealed an autosomal dominant LDS type 3, secondary to full deletion of the SMAD3 gene and some variant of the COL5A1 gene, which didn't have any clear significance. So that kind of, takes us off into what we're going to be talking about today. So let's kind of set some foundation of our understanding of aortopathy. So how do we define aortopathy? So according to the American College of Cardiology, aortopathy is defined as pretty much any condition that can lead to aortic dilation, aneurysm, dissection, or rupture. So that encompasses a lot of different things. When I was going through this, I really wanted to, for my own understanding, and hopefully for all of you all's understanding as well, to try to categorize or create a framework on how to understand aortic disease. So this is what I came up with. So you either have the chronic aortic diseases or you have like acute aortic syndromes. It's kind of how I like to think about it. The acute aortic syndromes are going to include obviously acute aortic dissection, life-threatening things that need to be, taking care of emergently intramural hematoma, for example, penetrating atherosclerotic ulcer, for example. On the chronic side, you kind of have three broader categories, include congenital diseases, genetic or heritable diseases, and then you have the acquired diseases. Under the congenital diseases, you have bicuspid aortic valve, coarctation of the aorta, for example, tetralogy of Fallot, truncus arteriosus, things that we learn about in med school, and that we may not see all that often unless you're, in adult congenital or structural or even CT surgery. In terms of the genetic and heritable diseases, you have the syndromic and non-syndromic is how we kind of classify them. The syndromic, including Marfan syndrome, Loeys-Dietz, and then vascular Ehlers-Danlos. And then for the non-syndromic, really is just going to be the familial, thoracic aortic aneurysms and dissection syndromes. Those have a genetic component as well. So this is kind of a framework to kind of help. Additionally, you have acquired aortic diseases, which include things that you have from age and nutrition and smoking and things like that, which is your atherosclerotic or degenerative aortic disease. And then you have your inflammatory aortitis. Now, this is not all encompassing by any means. There are so many different aortic diseases and that kind of fall under these categories of chronic versus acute, but these were some of the main ones. So I just want to kind of give you a starting point on how to categorize these in your mind. Also, I should point out that, because of my OCD, I have them color coordinated to try to help us kind of remember. So obviously, the red is going to be the things that are more acute. Chronic are the things that are blue. And so everything that's blue here in the background is to remind you that it's chronic. Everything that's congenital here is green to remind you of that. And we'll kind of follow this color theme throughout the presentation to try to help you, be able to keep these things in their correct buckets. The specific diseases that I will go into a little more depth on include bicuspid aortic valve, Marfan syndrome, Loeys-Dietz syndrome, which was the opening case, if you didn't catch that, atherosclerotic or degenerative aortic disease, and acute aortic dissection specifically. So in addition to classifying these aortic diseases, how do we kind of categorize them or define them further? This is what I came up with. I think for all of these, it's important to understand these 9 different components. So if you can pretty much break it down into the epidemiology, like how prevalent are they, who tends to get these diseases, the demographics, usually like the peak onset or like the age groups that you'll probably see with, different aortic dissection or aortic aneurysm. The pathophysiology, I'm a big, we're all kind of pathophysiology people because it helps you understand the disease process, and it also helps to inform therapies and interventions. It's very important to understand the risk factors in addition to the screening and the testing methods and what the preferred imaging modalities are, because they do change based on the disease location within the aorta and the actual pathophysiology of the disease. Also the location of the disease, which I just touched on, the different therapies, and then the surveillance strategies. So that's how we're going to kind of move through as we talk about these different aortic disease states. So more foundational things here. Let's start off with just a quick refresher of normal aortic anatomy and physiology. All right. So here, the aorta is pretty much broken up into 5 different sections, okay? So you have the aortic root, which technically starts with the aortic annulus and goes up to the sinotubular junction. And then you have the ascending thoracic aorta, which goes from sinotubular junction up to the innominate artery. And then the arch itself is really just those 3 main branching vessels that, supply blood flow to the upper body, which include the innominate artery, the left carotid artery, and the left subclavian artery. And then the descending aorta is really going from the left subclavian artery down just below the diaphragm, and then you have the abdominal aorta. If you look over here, this is another way to kind of, define the aortic anatomy. This is really based on 11 different sections that's based on landing zones. And this is really important for our cardiothoracic surgery colleagues, because these zones, like based on where they do like their endographing and different things like that, the different zones kind of help to predict surgical outcomes. And so not that you have to memorize all of these, but just want you to be aware that these landing zones do exist and why they're important. Next is kind of, my favorite slide so far, being a, physiology guy, is understanding the structure of the aortic wall is going to be very important in understanding, the different diseases of the aorta. So as you can see here, we have the three layers. We have the innermost layer, which is the intima, the thickest and middle portion of the aortic wall, which is the media. Then you have the adventitia. Each part of the aortic wall plays a crucial role in the function of the aorta and their integrity, and essential for cardiovascular health. So the intima, the structure, is usually made of a single layer of endothelial cells, a subendothelial layer of connective tissue, and an internal elastic lamina. The endothelial cells provide a smooth surface for blood flow and are involved in regulating vascular tone, blood clotting, and immune responses. The internal elastic lamina allows for flexibility of the artery and accommodating different pressure changes with each heartbeat. Clinically, this is important because damage to the endothelium, like from atherosclerosis, can actually lead to plaque formation, which has increased the risk of stroke, heart disease, and aneurysms. And the endothelial dysfunction is a critical early step in many vascular diseases, including hypertension. For the media, the middle layer is composed primarily of smooth muscle cells and elastic fibers. This is the thickest part of the aorta. It's pretty much comprised of more than 50 layers kind of sandwiched together in a small cross-sectional area. And it really helps to create that strong integrity and durability of the aorta. It also has like the elastic fibers, which help for the elastic recoil of the aorta as well. The smooth muscle cells of the media contract and relax to help regulate the diameter of the aorta, which is very important for helping to control blood pressure. And then we already talked about the elastic fibers kind of helping, to have that elastic recoil. Clinically, this is very significant because a loss of the elasticity in conditions like Marfan syndrome or normal aging can lead to aortic aneurysm and dissection. And the abnormal smooth muscle activity, like that you may see in hypertension, can contribute to atherosclerosis and kind of make the aortic wall more stiff. The adventitia, which is the most outer layer, is pretty much made up of connective tissue, collagen as well. But it really helps to anchor the aorta to the surrounding tissues and kind of protect it from external pressures. So when it comes to like blunt trauma to the aorta, like the adventitia, kind of helps protect from that as well. So overall, the reason why I kind of go through this is because as we're talking about the different aortic diseases, you kind of want to think about what's happening, at the cellular level as well, and what layer of the wall is actually being affected when you're thinking about each of these diseases. Once again, for the media, that's the medial portion, because that's most of the wall integrity. When you have weak spots in the media, that's how you get dilation, aneurysm, things of that sort. And that's where you see like how a lot of your connective tissue disorders actually play into this part of the wall here. And then when you're thinking about aortic dissection, actually there's a tear in the intima. So there's, destruction of the wall right there. And then when you come to the adventitia, you think about blunt trauma, but you also think about atherosclerosis as well. So let's talk about aneurysmal aortic disease. So how do we define an aortic aneurysm, and what is an aortic aneurysm? We already know that it's bulging out or weakening in the wall of the aorta that can ultimately lead to increased risk of dissection. But how do we define an aneurysm? So traditionally, when it comes to, arterial disease, an aneurysm is defined as an outpouching or a diameter that is 1.5 times that of the normal vessel diameter. And that may work fine for the descending aorta and even the abdominal aorta, but for the aortic root and the ascending aorta, that classification just doesn't work all that well. So we really don't go by that. The reason why it doesn't work that well is that if you think about the normal let's say, ascending aorta diameter is about 3.5 centimeters. If you wait until it's like 1.5 times that diameter, you'll already be at 5.3 centimeters. And by then it's kind of a little bit too late in terms of, them being at higher risk of bad things happening. So they actually, studied this. They actually looked at, at what point when people were sent to have intervention or had aortic dissection where they needed surgery, at what point, at what aortic size did those, negative things take place. So if you look here, when you get to about 4 to 4.4 centimeters of the aorta, when you go beyond that, then you realize that there's a lot of things, that things kind of get more serious after that point. So instead of using that 1.5 cutoff, we actually use like an aortic size of around 4 centimeters, 4 to 4.5 centimeters. Now this actually, kind of varies based on what the underlying, aortic disease is, and we'll kind of talk about that more. But this is just kind of, some general guidance. There's many different ways that we try to, keep track of the aortic size and diameter, and because the higher the diameter, and once you get to certain thresholds, you're much greater risk of dissection. So the Z-score is something that we don't really use, in our current practice because we mostly see adults. We're not like pediatric cardiologists, but the Z-score is usually used in pediatrics, and what it's made up of is pretty much it's a normogram because kids go through growth spurts and different things like that, and it's really hard to try to correlate in adolescence, their height, their weight to the aortic size. So instead, they created a normogram, and that's what they use the Z-score for. It's not really all that accurate. They have different calculations for the Z-score, and all of them don't correlate well. So we just kind of don't use that at all. However, we do use the aortic size index and aortic height index. Well, if y'all, when we're reading our echoes, a lot of times we're indexing the aortic size to see, is it normal? Is it abnormal? The aortic size index takes into account, the PSA as well as the aortic diameter. And actually, there was a study in 2006 that actually showed, that was published in 2006, that actually showed that aortic size index was a better predictor of, of complications related to aortic diameter compared to aortic diameter alone. And so that's why we like to use that. Sometimes we also use cross-sectional area to height ratio, because the aortic size index, aortic height index is really good for people who are within like 2 standard deviations of, height in the population. But if you have somebody who's super tall or somebody who's super short, then a cross-sectional area to height ratio could be helpful. The cutoff for that is usually around 10 centimeters squared per meter. That's usually the cutoff that we use, for us to kind of intervene on or do surgical repair. So in general, different aortic pathologies have different features that will make them high risk, but there are some overlap and some common themes that we should consider. Rapid aortic growth is always going to be a common theme for something that's going to be more high risk. Rapid aortic growth includes usually a growth of about 0.3 centimeters per year. So if you see that or higher, then that's considered to be rapid rate of growth. Also, family history of aortic dissection is something that could be, like, for example, in our opening case, the gentleman's mother had a dissection. And so once again, that would make him very high risk. And also aortic coarctation, the root phenotype, aortopathy as well. So let's go into another case. So a 45-year-old male presents with progressive exertional dyspnea, intermittent chest discomfort, and occasional lightheadedness. He reports a history of mild aortic regurg, diagnosed maybe in his late 20s, but otherwise he's been asymptomatic up until this visit. On exam, he had a high-pitched diastolic murmur noted along the left sternal border, and carotid pulse is brisk with a wide pulse pressure. His blood pressure is 130 over 80 millimeters of mercury, and there's evidence of early left ventricular dilation. His laboratory workup was significant for slightly elevated BNP level. His echo pretty much showed that he had some mild AI and a dilated ascending aorta measuring 5.3 centimeters. and he also had a little bit of LV enlargement. And the CTA confirmed that he had an ascending aortic aneurysm. So now going into our first, so this was kind of a clinical clue for someone who has a bicuspid aortic valve. So once again, remember I kind of gave you those different categories and ways to kind of understand the different disease. So we're just going to go through those for each of these disease states. So bicuspid aortic valve is usually about 1 to 2% of the population. It is the most common congenital cardiac anomaly, and it does account for about half of the aortic stenosis cases that we see in adults. So it's something that, you're definitely going to run into if you haven't already. As far as demographics, there is a male predominance, 3 times as much. And the aortic aneurysm formation often becomes significant in about middle to late adulthood. So if you see in this example, this gentleman was in their 40s. So so the pathophysiology. So once again, pathophysiology people, we like to understand what's actually going on so we can help inform our treatment plans. So the pathophysiology behind the bicuspid aortic valve and how that leads to aortic pathology is that a lot of times the people who have bicuspid aortic valve, they also have some genetic defects in the extracellular matrix that cause weakening of the vessel wall as well. And then just from a physics standpoint, having 2 cusps instead of 3 create abnormal flow dynamics and actually increases the amount of stress and tension on the ascending aorta and aortic root. And that's called shear stress induced remodeling. You also have cystic medial necrosis, similar to what is seen in Marfan syndrome, where you kind of have, apoptosis of the smooth muscle cells in the media of the vessel wall. You have fragmentation of the elastin fibers that are in the media of the wall, and that leads to reduced structural integrity. Risk factors for bicuspid aortic valve are a lot of the inheritable syndromic disorders, including Loeys-Dietz syndrome, Marfan's, as well as Turner syndrome. Up to about 30% of people with Turner syndrome actually have bicuspid aortic valve as well. Additionally, prevalent family history, even without a, inherited syndromic disorder, and also coarctation of the aorta. So for screening and testing, the guidelines generally recommend that you screen all first-degree relatives of the individuals who have bicuspid aortic valve. Patients who have aortic dilation or aneurysm, you're going to screen them as well. People with other congenital heart defects, just because a lot of times the bicuspid aortic valve kind of tags along with other abnormal congenital disorders. And then patients with unexplained aortic valve dysfunction, especially in like younger people, you kind of want to look for bicuspid aortic valve. And then individuals who have a family history of aortic dissection or aneurysm. So as we go through the different imaging modalities for different diseases, there are some different preferences in the imaging modality. Usually this is driven by the location of where the disease is located. And that's going to inform what, imaging technique you're going to use to kind of hone in on that area of disease. So because the bicuspid aortic valve, a lot of location of the disease is actually in the aortic root or the ascending aorta, we like to start off with an echocardiogram, a surface echo, to really look at that, because you can see, the ascending aorta and the aortic root pretty decently there. And then MRI and CT. MRI and CT are pretty, comparable for the most part, but you have to think that a lot of times these patients are, being screened and followed ever since they're young. And so if they're going to have, let's say 30, 30 follow-up imaging over the course of, 30 years or so, if they do it every year, for example, that's going to be a lot of radiation. And so for that reason, MRI, which has less radiation than CT, is sometimes preferred. But it's not that MRI is all that much better than CT. It's just you want to try to reduce the amount of radiation for these individuals. So therapies, what do we have in our toolbox to kind of help these people? So beta blocker therapy is going to be, a cornerstone of just the medical management in general. Beta blocker is part of the category of medication that we call anti-impulse therapy. So every time, the heart beats and you feel that shear stress on the wall of the aorta, the beta blockers kind of help to reduce that impact a little bit and that shear stress. But then obviously we have surgical intervention. If you look at these here are taken from the updated 2022 American Cardiology College of Cardiology and American Heart Association guidelines for the management of aortic diseases. And if you see here, the class 1 indication is really right around 5.5 centimeters to have surgery to replace the aortic root, the ascending aorta, or both is recommended. So that's kind of one of the key cutoffs. Now, it's also important to note that you can have surgery before it reaches 5.5 centimeters. For example, if it's 5.0 centimeters and a patient has other high-risk features, then you can also consider doing it a little bit sooner. If you look at the class 2A indication, actually using that cross-sectional area to height ratio, that cutoff of 10 centimeters squared per meter, which is what I explained to you before, is also an indication. Okay. Now, the surveillance strategy, there's a lot of guidance. Sometimes there's general consensus, sometimes there's not. Sometimes it's more of understanding your patient, what their symptomatology is, and kind of having shared decision making. However, generally speaking, if there's just mild dilation, you can, check an echo once every year or once every 2 years. Or if there's more rapid growth, which we kind of defined that earlier, you can use MRI or CT. You can do that biannually if you need to. The guidelines specifically say if you have bicuspid aortic valve and you have undergone previous aortic valve repair or replacement, you really want to kind of use, and the diameter is greater than 4 centimeters, then you got to have lifelong surveillance. Now, when it talks about the frequency of that surveillance, it kind of like leaves it up to the provider. It says it needs to be kind of, determined by the rate of growth and different factors. So just keep that in mind. So we have another case. We have a 32-year-old male who presents with increasing shortness of breath, intermittent sharp chest pain, has a history of scoliosis, and reported tall stature with long limbs since adolescence. On exam, 6'4", long, slender fingers, high arched palate, ding, ding. A murmur consistent with aortic regurgitation is heard along the left sternal border, and his blood pressure is normal. Now, eye exam reveals lens subluxation. An echocardiogram shows a dilated ascending aorta of 4.8 centimeters and mild aortic insufficiency. Genetic testing confirms a mutation in the FBN1 gene. So this is a clinical scenario for Marfan syndrome, if you didn't catch that, with the lens subluxation and a high arched palate. So the epidemiology of this is pretty much 1 in 5,000 individuals worldwide. It's autosomal dominant, and about 25 to 30% of the cases are de novo mutations. In terms of demographics, it's usually diagnosed in childhood or early adulthood. And then there's a male predominance. Well, there's not a male predominance. They're actually equal. Males and females are equal here. If you look over here, this is just a picture of your dilation here. And then here are some of the clinical features that you see with Marfan syndrome. It's very important that when you see your patients in clinic or you're meeting a patient for the first time, to actually kind of look out for these different characteristics, including the chest deformity, and then the eye exam as well, and their spinal deformity and like the length of their limbs and their fingers and things of that sort. The physiology behind this is usually there's a mutation in the FBN1 gene, which encodes fibrillin-1, which is very important to the extracellular matrix. A defect in this protein actually caused the elastic fibers in that medial layer that I told you about in the aortic wall, and it leads to structural weakness. You also get a production of excess TGF-beta, and then the excess TGF-beta actually leads to cystic medial necrosis, which is where you have the apoptosis of the smooth muscle cells, you have the fragmentation of the elastin fibers, and then that middle part of the wall actually gets very weak. The risk factors include family history and known genetic mutations, of course. So what do the guidelines say? So it's important to definitely screen all first-degree relatives of someone who has Marfan syndrome. You can also screen them just looking at their characteristic and clinical features. And then young adults with aneurysm or dissection, those are people you want to screen as well. If you look here, it talks about using echocardiogram kind of as the initial assessment. And then, you can use that to follow up as well. But usually CT or MRI is usually more so for like the thoracic aorta and also for follow-up. But the initial assessment that you want to use to see if they have aortic disease is going to be the echo. And the reason for that, once again, is because the location of the disease, which includes the aortic root and the ascending aorta. It's also something important to point out here that if you look here in this class 2A indications, in adults with Marfan syndrome, after the initial echo, CT, or MRI, it's reasonable to confirm the aortic diameters and to also look at the remainder of the thoracic aorta. So one of my attendings actually told me this when I was on my echo rotation at the VA, is that if you see an abnormality, like if you're just reading surface echoes and you see an abnormality in the ascending aorta, the aortic root, you should, depending on how severe it is, you should consider just scanning and seeing what the rest of the aorta looks like, because there could be other disease that you're missing out on kind of further down, whether it's the descending aorta or the abdominal aorta. So please keep that in mind. When it comes to therapies for Marfan syndrome, once again, beta blockers are going to be a cornerstone for the anti-impulse therapy. But also here in Marfan syndrome, they actually recommend using ARBs. So that also helps with, kind of slowing the dilation process. And it's actually shown to be helpful in these patients. Surgery is usually indicated when the aortic diameter is 5 centimeters or greater. But once again, you can always do it, at a slightly smaller diameter, maybe about 4.5 centimeters, if they have high risk factors. The surveillance strategy is usually going to be an annual MRI or CT or echo, but if it's rapidly growing, you can surveil them a lot sooner than that. That's going to be a common theme. It's like they'll have some general recommendation in terms of, when you get the initial assessment, then if they have some type of surgical repair intervention, the initial follow-up, and then as they're more stable, you can kind of space out that follow-up imaging. Or if it's growing more rapidly, then you're obviously going to speed that up as well. You can do it a lot sooner. Next, we have Loeys-Dietz syndrome. I didn't give you a case here because I gave you one at the beginning of the talk. But Loeys-Dietz is actually pretty rare. It's 1 in 100,000 individuals. It's autosomal dominant. And 75% of these cases actually come from new mutations that were not inherited. The demographics is usually diagnosed in childhood or early adulthood, which you can kind of see a theme here when it comes to these syndromic disorders. And also, if you haven't noticed, the color scheme here matches our color scheme from our flow diagram in the beginning. So the orange here, or the dark orange, kind of lets you know that it's syndromic. This lets you know that it's inherited. And then the blue lets you know that it's chronic. I should have pointed that out sooner, sorry. I put so much thought into it, and then I didn't mention it later. Anywho, the pathophysiology of Loeys-Dietz syndrome is that it's a mutation in the TGF beta receptor 1 or 2 genes, which encode receptors for transforming growth factor beta. And once again, earlier, even in Marfan syndrome, when we talked about how a defect in the fibrillin 1 gene can actually affect TGF beta and cause TGF beta overproduction, and then how that leads to weakness of the medial layer. You see that here as well. So some of their, pathophysiology is similar, but it's a different underlying problem here. You also end up having abnormal tissue remodeling due to the excess TGF beta signaling. And then you also have elastin fragmentation and cystic medial necrosis that we've been kind of talking about this whole time. Risk factors, family history, and known genetic mutations. For screening and testing, once again, common theme, first-degree relatives, patients who have the clinical features of Loeys-Dietz syndrome, and then young adults with aneurysm or dissection. Once again, based on where the area of the disease is mostly seen, that kind of guides what your imaging modalities are. A lot of times you see disease in the aortic root, like dilation of the aortic root, but Loeys-Dietz is a little bit more kind of broad and expansive in terms of like where you may find disease within the aorta as compared to Marfan syndrome. And so for that reason, MRI is strongly recommended as well. And once again, these are often going to be people who are, getting multiple radiation exposure over several years. So try to reduce that by preferring MRI over CT. But in the acute setting, if something's going on, obviously you can get a CT a lot faster than an MRI. Okay, now let's look at the therapies here. So one thing that's a little bit different about Loeys-Dietz syndrome as compared to Marfan syndrome is that they actually recommend surgical intervention based on the genetic variants. So if you see here in in this table right here, the class 1 indications for surgery are for someone who has a aortic diameter of 4.5 centimeters, who don't have high risk features, but they have kind of like a high risk genetic variant. And then if class 2B recommendation and 2A recommendation is that if you kind of have this high risk variant and you have high risk features, then you can go ahead and consider surgical intervention sooner at a smaller aortic diameter of 4 centimeters, and so on and so forth. Once again, beta blockers and ARBs are going to be, good medical management for these patients. The surveillance strategy for Loeys-Dietz syndrome is usually going to be an MRI or CT 6 to 12 months or more frequently if they're rapidly growing. And so this is kind of outlined here in the guidelines, but that's about 6 months, and so on and so forth. So I want to give you a quick summary about genetic testing in general, and this has kind of been brought out as we kind of progress through this talk, is that if you have the clinical features of a syndromic inherited thoracic aortic disease, then you get genetic testing. Okay, if you have a family history of somebody who has thoracic aortic disease, or you have aneurysms or things like that, it's probably good to get genetic testing. And then if you're young and you have thoracic aortic disease, genetic testing, okay? Now you have some sporadic cases, some patients who are, greater than 60 years of age, so more on the older side. So you kind of need a little bit more support before genetic testing is recommended. Those things including, you have an at-risk family, you have a family member who has thoracic aortic disease as well. So then they may recommend imaging. And then if you see that there's an abnormality on imaging, like there's aortic dilation or aneurysm, then go ahead and go down the genetic testing pathway. Here's a word about cascade testing for at-risk relatives. So pretty much if you go and get your genetic testing, or your patient gets their genetic testing, and they have a like a gene mutation that's highly associated with one of these aortic diseases, then it will be good to go ahead and do cascade testing for the at-risk relatives, and then also to test their offspring as well. All right, so for our next case, we have a 68-year-old male with a history of hypertension, high cholesterol, smokes, new onset exertional chest pain, shortness of breath over the past month. We kind of hear these stories, over and over again. He reports a history of intermittent mild angina over the last several years, but his symptoms have gotten worse more recently. On exam, his blood pressure is elevated, and he has a faint systolic murmur in the right upper sternal border. He has a slightly diminished femoral pulse. His laboratory tests revealed that he had pretty high cholesterol and high sensitivity CRP level. His EKG was pretty much normal, didn't have too many changes, but his echo did demonstrate a thickened calcified aortic valve and some mild AS and a dilated ascending aorta of 4.7 centimeters. And CTA actually revealed that he has some atherosclerotic aortic changes and some plaque formation as well, and also into his iliac arteries. So this is a clue for, atherosclerotic degenerative aortic disease. This is, far too common in our society, actually, 5 to 10 per 100,000 people per year. A lot of us look at CTs and we see this all the time. The aorta is just, covered in calcium. The prevalence is usually 2 to 5% in older adults. And as you get older, obviously, you have more time for that plaque to accumulate. So the prevalence increases with age. It tends to be more common in males, and it primarily affects individuals who are over 60 years old. Once again, you need time for that plaque formation to occur. The pathophysiology of how this actually plays into aortic disease, aortic dissection, aortic aneurysm. You have endothelial dysfunction and lipid deposition that leads to chronic inflammation, And then you ultimately, like the neutrophils come in, and then you have destruction of smooth muscle cell. You also have apoptosis. And then normally your vascular smooth muscle cells stabilize the aortic wall, but in atherosclerosis, the chronic inflammation and oxidative stress actually cause death of those vascular smooth muscle cells. So it causes thinning of the medial layer and reduced tensile strength. Risk factors are going to be smoking, hypertension, hyperlipidemia, family history of AAA, things of that sort. So the screening and the testing for atherosclerotic degenerative aortic disease, because of the location of the disease, is usually going to be descending thoracic aorta and the abdominal aorta. A lot of the screening is tailored towards, abdominal aortic aneurysm screening, and that's usually going to be by method of ultrasound for the descending thoracic aorta, more so CT. So here we have a clip from the ACC/AHA guidelines here that kind of guide us on who should get screened for this here. So if you're less than 65 years of age, men or women, you have multiple risk factors, you can consider getting an ultrasound. If you all remember from the internal medicine training, the USPSTF guidelines actually say it should be men generally between the ages of 65, 75, who have ever smoked should have at least one screen for AAA. But the ACC/AHA guidelines actually include both men and women. So this is actually a more inclusive guideline here. So just keep an eye out for that. Therapies are going to be smoking cessation, got to stop smoking, got to control the blood pressure, and pretty much control the risk factors. And then they recommended a vascular repair for people who have a diameter of 5.5 centimeters in the abdomen or 6 centimeters in the thorax. I saw a little bit about statins. They said, hey, somebody has atherosclerotic disease and they have a thoracic aortic aneurysm, that is reasonable to put them on a moderate to high intensity statin as well. And the surveillance strategy is actually kind of based on the size. So the smaller it is, you can kind of space out the imaging. You can get it once every 3 years. If it's kind of, moderate in size, you can do it yearly. And if it's, large in size, then you can do it every 6 months. Another case here, we have a 52-year-old male with a history of hypertension, presents to the emergency department, sudden onset severe chest pain. He describes as tearing that radiates to the back. It's diaphoretic, visibly in distress, blood pressure super elevated in one arm, not so much so in the left arm. And there's a difference in pulses between the two arms, obviously. His heart sounds are distant. Systolic murmur is noted at the left sternal border. And the physical exam reveals signs of shock, including tachycardia and weak peripheral pulses. Now, the laboratory workup revealed elevated D-dimer, chest X-ray, widened mediastinum, and contrast-enhanced CT confirms an aortic dissection, acute aortic dissection with tear originating in the ascending aorta and extending into the arch. So this is aortic dissection here. The incidence of this is usually 3 to 4 per 100,000 people per year. If you're looking over here, this very small, hard to see photo, I apologize, is how we kind of classify the aortic dissections. You have the older Stanford classification that's pretty much says, hey, does it include the ascending aorta or does it not? But then you have a more, detailed classification with the DeBakey classification here. The demographics usually more common in males, about a 2-to-1 ratio. And then the type A dissection typically occur in individuals who are a little bit more on the younger side. And then the type B dissection is more common in older adults. Younger patients who are less than 40 years old with aortic dissection often have some underlying connective tissue disorder. So it's important to screen these individuals as well. The pathophysiology is that there's generally a tear in the intimal layer of the aorta, and then it creates a false lumen, and that false lumen propagates and then along the vessel wall. The risk factors, hypertension is most significant risk factor. Genetic aortopathies as well, and then smoking, atherosclerosis, and prior cardiac surgery also play a role. The screening, so we kind of all learn this in medical school as well, is that if you have a patient who's coming to the emergency room, with severe chest pain, sudden onset, that's like tearing, going to the back, difference in bilateral arms, all the things that we kind of gave in that clinical scenario, that's gonna, kind of cue you in, hey, you might want to get a CTA, you might want to get it right away. Sometimes patients are too unstable for CT. So there's been instances where they just literally did a stat bedside TEE just to take a look at the aorta that way. Once again, the location of the disease is usually going to be in the ascending or the descending aorta. You can do surgery, which is usually indicated for type A dissections, or you can do TVAR, which is usually indicated for type B dissections. And then the surveillance strategy is going to be 3 to 6 months, and then as they get more stable, you can space it out to once a year. So this is a clip from the guidelines as well, kind of going over what we already talked about. If it's a type A aortic dissection and there's some complication related to it, for the most part, like if there's tamponade, ruptured tamponade, stroke, or a malperfusion syndrome, then surgery is generally recommended. For the type B aortic dissections, TVAR is definitely going to be recommended more than likely if there's some level of complication. So that's just a general way to kind of think about the treatment approach. So we talked about a lot of different aortopathies, okay? This is a nice summary table, kind of condenses everything with, the abbreviated form of what we talked about today. If, taking a snapshot of this might be helpful, especially when you're seeing your patients in, clinic or coming across echoes and you're seeing these different, some dilation and different things like that. So this is just summarizing what we already talked about. This is also from the ACC/AHA guidelines. This is just a summary of the different imaging modalities. It's kind of telling you like the differences between CT, MRI, surface echo, TEE, and ultrasound. I kind of try to, throughout my presentation, focus more on, the practical approach and like where the disease is and how you're going to be able to, see that part of the aorta the best. But this will tell you more about, the spatial resolution, the temporal resolution, and things of that sort, and how available and portable the imaging modality is. The ACC/AHA guidelines, the update in 2022, kind of had like some 10 takeaway points. I kind of summarized them here for the most part. Number one is just how we kind of define aortopathy, which we already went through. The genetic testing, early genetic testing is crucial for accurate diagnosis and personalized management. So keep that in mind. And then screening family members, especially all first-degree relatives of those who have some type of inherited disorder, whether syndromic or not. The imaging modalities, understanding that surface echo is the primary imaging modality in most of these, with the cross-sectional imaging with CT or MRI, being used for follow-up in a lot of cases. The surveillance, we do surveillance previously with using like Z-scores, but you can also adjust the frequency based on what their underlying genetic condition is and how rapid the growth of the aortic diameter is. We went through the medical therapy. Beta blockers and ARBs are really going to be, a cornerstone of medical therapy for the majority of these aortopathies that we talked about. And then surgical intervention. Once again, you can have prophylactic aortic surgery is recommended, but it's going to be based on the aortic dimensions, their underlying disease, and if they have the presence of high-risk features. We obviously want all the patients to exercise, but also try to limit the amount of shear stress that's placed on the aorta as well. So we have to kind of guide our patients with that. And then, multidisciplinary care is really important. Reading through the guidelines, they actually recommend kind of like these multidisciplinary aortopathy teams that are specialized. That includes, geneticists, cardiologists, surgeons, and so forth, to kind of work together to provide the best form of care. And then the long-term management is that a lot of these patients have issues in childhood, like congenital disorders or inherited disorders. So we do not want these patients to be lost to follow-up when they transition into adulthood. So thinking about how to smoothly transition, the pediatric patients into adult care is something that we should take into consideration. Well, that pretty much sums up my presentation. Here are some of my references. And I just want to give a special shout out to my wonderful family. A lot of y'all know that I have, a wonderful wife and 4 kids, but you've never really seen them. And so here are some friendly pictures. This is Zamira. She's my youngest. She's 6 years old. Here's Martin Jr. He's 7 years old. They played soccer for the first time this year. I have my 2 teenage girls. This is Genesis. She's 15. Amira, she's 14. And then this is my lovely wife, Imelda. So that concludes my presentation. Thank you all, and I'm ready to accept any questions.
Martin, thank you so much for that really thorough review of aortic disease. I just wanted to, for the fellows that are thinking about the boards and studying for the boards, there's a lot of very testable material that Martin covered. A lot of those syndromic things will come up. And I can't remember, Martin, if you may have mentioned, so if I'm repeating this, but one of the things that comes up with Loeys Dietz is that bifid uvula that they have. So it looks like the uvula's got like sort of a fork in it, and that is very testable on the board. So really great review, and hopefully some things that our fellows can take away from. We'll open the floor for any other questions.
Martin, this is Mahmoud. Very good presentation. Thank you very much. Excellent demonstration of this. I have a question for you.
Yes.
And while you were researching this and preparing for this talk, what did you find? Of course, you know where I'm going to go with this. How did you find any correlations with certain aortopathies and cardiomyopathies? How often this happens? And what's your thoughts on that? And if you've seen anything so far in your practice?
Yes. So, I'm sure there are. During my kind of research for this specific topic, I didn't really take a deep dive into the different cardiomyopathies and how they interplay with these aortopathies. That's something I'll have to dig a little deeper into, or, if you kind of have some insights, I'll bet you wouldn't mind sharing with us, that would be helpful too.
Yeah, some of these, especially these syndromic aortopathies and inheritable genetic disorders for aortic disease, sometimes they are associated with certain cardiomyopathies, usually it's not that common. However, this is something that you want to be aware of, especially if you find a patient with aortic disease and part of a syndrome, Loeys Dietz, Marfan, etc. You want to also, on top of that, if they have an abnormal looking left ventricle, to really think of
Gotcha.
associated cardiomyopathies with that.
Mm-hmm.
Certainly in our patient population that we see in the advanced heart failure realm, there are certain patients that got even advanced heart failure and needed a transplant at a younger age because of that. So just something to keep in mind. They're not very common. It's not really commonly associated, but it's something that to keep in mind when you're evaluating these patients.
Absolutely. Thank you so much, Dr. Abdi. Okay. Well, thank you all so much. I really appreciate your time, and thank you for all you do, taking care of our wonderful patients. I'll see you guys around.
The preceding program is copyrighted by Emory University.